Hi, my name is Akshay, and I'm one of the co-founders and CTO of a wonderful company called Cerebriu, if you're able to pronounce the name. We are right by from Medias there. We focus on using machine learning to assist scan acquisition, and today I'm going to talk about a few applications. What can we do at the scanner, and how can AI enable faster acquisition or faster decision making, or help the radiographer be more confident about acquisitions, right? So today's talk is about AI assisted decisions at the scanner. So we all know the workload is going up, MR is more in demand. Scanners can be manufactured. Training people takes a lot of time. So the shortage is primarily around expert technicians and expert radiologists. Today we'll focus a little bit around the technologists and the shortage in technologists, and and how can we help them with AI. So why is automation needed? Because there is an increased number of requests in MRI scans with Alzheimer's drugs showing up. There is going to be an explosion of MR screening devices to see if REI is showing up in the brain. Aging population, and therefore we have to find a way to make sure that MR is utilized better than it is today. One way to do that is to automate the MR, make sure that the radiographer is more patient-centric, interacting with the patient, and let the machine do all the intelligence and the acquisition and the not the diagnosis, but acquire the right kind of images so that downstream the radiologist is able to do the best possible diagnosis for that patient. How do we do this? Is by automating certain tasks that radiographers are doing right now and make it into something automatic. It could be planning the sequence, patient placement, contrast decision, reduction of interruptions because they have found a lesion in the brain, or even raising alarms if they have seen something acute or something critical like an acute infarction. Therefore, I think automation is the way to go forward because the demand is today and not 5 years from now. So let's take a look at what are basic steps that happens at the scanner. So there is protocol selection, and that includes scan planning, that includes patient placement, and then there's the protocol adaptation part of it. And protocol adaptation means you look at the quality of the image. Is the image of the right quality? Is there a protocol change necessary? I mean, if a patient is uh, determined for a particular protocol and you see a lesion that is confounding the protocol, you need to switch on the fly. Can we automate that process? And then there's the most important, that's the contrast decision, whether to inject gadolinium in the patient or not. Can we automate that process as well? And in terms of response, the radiographer is also responding to whatever they're seeing. If they see an acute infarction, they have to call the clinical stakeholder as soon as possible. If the patient is not cooperative, they have to make sure that the patient, the acquisition is fast enough, but of enough diagnostic quality. So we'll see how Cerebriu is enabling some of these steps. So the first one we are looking at is called protocol change, or a smart protocol, that is on the fly adaptation of protocols as and when you find something in the brain. So shotgun imaging, at this point the protocol is decided based on a referral. A clinician says that a patient thinks that he or she has a headache. I think you have to acquire a brain with and without contrast. It's very unspecific. You don't know what's there in the brain a priori, so you tend to acquire everything possible to rule out all the lesions. We come up with another suggestion. Why don't the hypothesis be like this, that we acquire a few sequences, that is 3 sequences, and then at that point you have enough evidence to see if there is anything critical, any lesion, and then switch according to what you have found. And once you have found, let's say, an acute infarction, you can immediately switch to an MRA or a TOF and skip all the T1 and T2 images, because that will not add anything. It just adds redundancy. And switching to TOF or MRA can immediately tell you where the occlusion is. So an AI assisted algorithm can essentially sit there, keep analyzing the sequences as and when they are acquired, and then protocols can be switched as and when you have detected the sequences. Right? So how do we do this? We basically are a foundation model based system. We train on a large set of images unsupervised, and then we fine tune on a very small set of images. And primarily as a first step, we detect three main findings. So here we only need three sequences: diffusion, flare, and an SWI. And based on these three sequences, we are able to find all acute and subacute infarctions in the brain. We're able to find all tumors essentially and all kind of hemorrhages in the brain. So while the patient is in the scanner, when the third sequence is in there, we are able to analyze the images on the fly and then give a decision on what should you do next. We have not found anything, perhaps stop. If you have found something, then switch. For instance, if you find a meningioma in the convexity, then it's sometimes very difficult to find that. We will flag that. The radiologist is in a position to decide whether they want to inject contrast or not while the patient is in the scanner, instead of recalling the patient afterwards. So we did a very interesting study. And here we wanted to see what happens if a radiographer is made to make these decisions based on three scans. How good a radiologist is, how good a radiographer is, and how good AI is in picking these lesions based on three sequences only. And the results might surprise you. Our very colleague Heining has presented an abstract. So if you have any questions about this study, he's right there. So you can go and question him, not me. So here are some numbers. I'm only talking about sensitivities here because this is kind of important. For the neurorites, top performing, expected. The sensitivity is slightly lower for tumors based on three sequences. That could be because they don't have their favorite T2 sequence. The Apollo, which is our product, is on par. It's able to do almost as well as the neuroradiologist. What is surprising is the technologist. The technologist's sensitivity is much lower in picking up tumors, and that's okay because they're not trained to do that. They are trained to acquire images. But in large part of the world, the technologists are relied upon to find these lesions so they can call the radiologist to make an appropriate change. Right. So if you want more details on this wonderful study, please talk to Kai-Ning Cheng, who's sitting right here. Some examples here, very interesting examples. So the first one, caught by all readers, it's a infarction in the pons region or probably cerebellum. And all the readers have found that. Then you have a meningioma in the convexity P. It was caught by AI, it was caught by a neurorad, but was actually missed by a technologist. And these are very common cases that you see, that these small lesions are missed and then they're caught a little later and then the patient has to be recalled. But why not do it at the first try, right? And get the right image at the right time. The next decision is the contrast, right? And there are two kinds of contrast decisions that you could look at. One is contrast necessary or not? That is one thing. And the second thing is, these days, I'm sure everybody knows that there are a lot of studies looking at the amount of dosage in the amount of gadolinium dosage, and that can actually be, sorry, somebody's calling me at the wrong time. That can actually make a lot of difference, and not always low dosage actually works out. And we will have an algorithm that helps you decide when is low dose important, when is high dose important. For instance, if a patient has high grade glioma, you don't want to low dose the patient because you would like to see all the vascular structure in the brain. But if you know at the scanner that this is a high grade glioma, then you would probably go for a full dosage instead of the low dosage. So this is a very interesting work. Here's the top one is looking at the recommendation of contrast injection, right? So what is the ground truth here? The ground truth here is not the presence or absence of a lesion. The ground truth here is what eventually happens when a contrast injection is actually given, if whether it's an uptake or not. So if there is a low grade glioma, the lesion might be very big, there is eventually no contrast. So what is important here to see is the negative predictive value. We are very good at saying when is contrast not necessary. So you could have an infection, for instance, that looks like a tumor, but we would be able to tell you that, hey, you know what, this might be an infection. You don't need a contrast. A lot of studies, primarily headache studies, come in and there's not a lesion seen, but they have all been assigned to contrast. So we will be in a position to tell you with high degree of certainty that this case does not require contrast. In the bottom, you see the differentiation of low grade glioma versus high grade glioma. As we all know, in low-grade glioma, the contrast update is much low. So if you see the box plot there, which is the ground truth, and you see the right one, for low-grade glioma, there's absolutely no contrast, right? There's a little bit of variance, but there's no contrast. If you have a pseudo-generation algorithm, you want to be able to reproduce this. That means that if a low-grade glioma is there, the prediction should also have very little to no contrast. And that's what we see in the pseudo-generated images from ours. Even with the low-grade glioma, even if it is large, even when we correct it by the size of the lesion, we are very good at saying this doesn't require contrast, which means that for patients with low-grade gliomas, for instance, where there is a lot of follow-ups, you can decide to low dose the patient until the tumor differentiates into high-grade glioma, which is what we are good at. And on the right side, you see the classification. On the left is using the real, the blue one is using the real contrast, the AUC. If you just look at the real contrast image, can you tell low-grade versus high-grade glioma? Of course, biopsy is the only way you can tell it, but can you guess it? Our pseudo-GAD, which is a pseudo-contrast image based on non-contrast images, is very, very close to real contrast images. I'll show you some examples. So the different kinds of tumors, it's not just gliomas, it's all kinds of tumors, metastasis, meningiomas, schwannomas, everything. So this is where it actually works. The first column is the T2 image. The second column is the FLAIR image. The third column is the FLAIR image with an overlay to show you where the tumor is. The fourth is pre-contrast T1. The fifth one is our generated image, essentially tells which are the regions that are most likely to have high contrast uptake. And the last one is the true contrast. So as you can see, for some examples like here, there is a meningioma, and this is the real meningioma, sorry. And then we are able to predict very little amount of contrast uptake, even though the lesion is quite big. So we're not biased by the size of the lesion, we are actually biased by the pathophysiology of the brain. It doesn't mean that it works all the time. So there are some examples where it doesn't work. For instance, in cysts, sometimes we over-predict contrast in cysts, but adding contrast to such images or such patients is not of high risk. So this is a very interesting algorithm that we are coming up with. If you are interested, please do come by at booth 5519 to see these examples. And then the final example is treatment emergency. And here we are particularly looking at stroke. Identifying an acute stroke is not that hard. Lights up on diffusion. The primary thing is to tell apart from a T2 shine through and an actual ischemic image. And more importantly, whether you can intervene at that point. And in an MR setting, the most important decision is there a diffusion flare mismatch for the patient, so you can thrombolize the patient before you take either a perfusion or the next set of images. Right? So what we have been able to do is, with only 2 sequences, you acquire the flare and the diffusion. We're able to immediately tell you whether there is a flare diffusion mismatch for this patient, and even the degree of mismatch, saying that there's 10% mismatch or 20% mismatch or 30% mismatch. So you can make the decision of thrombolysis as soon as possible. So you can do that while the patient is in the scanner, so give them that extended time window due to the IV lysis. And the sensitivity and specificity is reasonable. As we all know, flare diffusion mismatch is a notoriously difficult thing to do. There's a lot of intra-rater variability, even inter-rater variability, and therefore these are, I think, pretty okay numbers in terms of determining who requires the treatment. Finally, how does it manifest? This is an example of our integration on the scanner. This is our software will be integrated on the Siemens workflow. So as you can see, the first few sequences are taken, the scout, and then the 3 sequences, that is the diffusion, flare, and SWI. And while the 4th placeholder sequence is being acquired, we come in and this the algorithm gives a response, and the technologist is able to respond to this and load the rest of the sequences automatically. They have the ability to go in and look at the image and saying that, okay, has the algorithm found the right image, and if you have more interested, please go to the Innovation Lounge and and contact our Siemens guys so they can give you more information about the product. So in short, we can make early in-scan decisions, and that is feasible with AI. It's not just about quality anymore, and we are able to protocol on the fly. We can determine the right findings that necessitate a change in protocol, and we are able to do that real time and highly reliably. We are able to be a very nice tech co-pilot for the technologists. We can do intra-scan alert for critical findings, which is with AI. We can also help you with administration of gadolinium, especially in resource constrained environments where there are no on-call radiologists. We will be able to give you confidence in understanding whether contrast injection has to be given to the patient or not. And we can always mitigate risks through clinical supervision. If you have any questions, please find us at 5519, and thank you very much for your time.